Hello. Okay, I am recording. So most of the other talk was, again, those problems. Now here's troubleshooting. This is part of trauma. Patients often come in with arrhythmias. And remember, arrhythmias is a general term. There is tachyarrhythmias. I want to say the slide before it talks about, but these guys, the heart gets bumped around the chest. So you need to listen for any abnormal sounds, any abnormal respiratory sounds. Let's see if someone remembers. Okay, so these patients usually come in, when we say shock, usually it's from low blood pressure, and they don't have good tissue perfusion. So, I do remember talking about that. Low blood pressure, low tissue perfusion, tissues die or anoxia or don't get enough oxygen, and we get lactic acid and acid-base imbalance. So it sets us up. One thing that when I have low blood pressure or hypotension, there is a series of things that you can do. One thing is that if we're doing anesthesia, you want to decrease your anesthetic, potentially give a fluid bolus. You can give colloids. Okay, I do remember talking about this. The colloids help keep it in. And I talked about diaphragmatic hernia. But the steps to treating hypotension during anesthesia is decrease your anesthetic, potentially give a fluid bolus, and then you can use inotropic agents like dopamine. But dopamine would be like my last ditch effort. You can give pain meds to decrease your inhalant because inhalants lower blood pressure, and sometimes that helps. Okay, so responding in an emergency, which I talked about, always wherever you practice, you want to make sure that you know where all your emergency drugs are, your crash cart. So making sure that has to be inventoried if anybody opens it. So you have to check all of that. So these are the problems that will happen. And let me just talk about how to troubleshoot these categories. If they won't stay asleep, and so you feel like they're moving, blinking, chewing, tachycardic, one of the reasons is, you could have them too low. You didn't set the vaporizer, put the wrong anesthetic. Remember, they go in their own vaporizers, so make sure you put the right one. They can have a blocked tube or a tube that's too small and is leaking, so they're not getting their anesthetic. But think about it. If they don't stay asleep, then how do we also proceed? Is the tubing leaking? If they're breathing too shallow, an animal has to inhale enough anesthetic to stay asleep. So if they have a very shallow respiration, sometimes they don't take deep enough breaths and take in the anesthetic. Or say your oxygen flow is too low, so you don't have adequate oxygen flowing. So what do? Check your vaporizer. There's no way to really open it up and say, did you give the proper amount? Did you put the right agent in? They don't smell different. So if it's full, make sure it's full. Make sure you have it set properly. Make sure that the tube is not bent, kinked, or plugged, and check for a leak. Usually the way I do that is I squeeze the bag during anesthesia, put my face, and when you squeeze, you shouldn't hear anything and you shouldn't smell anything. And then, if you're worried about the machine, you can switch them to another machine. But I will tell you, gas anesthesia does not treat pain. So sometimes if you did not give a good pre-med and the patient is reacting to surgical stimulus, and you keep having to turn them up, you may need to give them another shot of butorphanol or an analgesic. But again, you want to make sure the anesthetic is getting to the patient. You want to make sure they're using what you're giving them. Okay, when I have breathing problems with anesthesia, it's kind of like, am I getting the stuff oxygen and gas from the machine to the patient. And then you have to think about all the parts along the way, and is everything functioning properly? Now, if they're too deep, how do I know they're too deep? Well, I told you pretty much my low is 6 breaths a minute. When you start, and because I have a lot of patients that breathe 8 times a minute, a patient breathing 6 times a minute, I'm watching very closely because that's bordering on really, really low. Sometimes they get pale. CRT is extended because typically they have low blood pressures. Now, this number is significant because I told you that top number, we don't normally like it to go below 100 for a systolic. If it's this, now this is not mean, this is the top number. So normally, like if you have a blood pressure 120/70 with a mean of 75, 120 is your top number. Anything below 80 is significant. And arrhythmias can be cold. So we're talking about temperatures. Now, I don't have an absolute body temperature number. You definitely want your patient usually warmer than 96, 97 degrees. But I've had patients colder. It's going to take you longer to recover a colder patient. But this is where we're getting no reflexes, no palpebral. Remember, corneal is where you actually touch the surface of the eye with like a drop of saline or with a moistened Q-tip. That's that's different than a palpebral. So palpebral is touching for a blink. Corneal is touching the cornea or the surface of the eye. Loose, flaccid means very loose. So loose jaw tone, pupils that look like saucers, very, very dilated. And then the pupillary light reflex is where you shine the light and look for pupil constriction. So if you're seeing a combination of those signs, what do I do? Well, the first thing you have to do is you have to decrease your anesthesia. And I've told you guys that I've had patients that I've been really concerned about. I've turned them off in the middle of a procedure. And if I'm wrong, then I have to turn them back up and get them under anesthesia again. But I'd rather turn them down because when you turn them down, it's not instantaneous where they start to recover from anesthesia. It's going to take some time for them to come out of anesthesia. So sometimes I've literally like shut them off and get that anesthetic out. I need to tell my veterinarian, if you have to interrupt them, I don't care if they're talking and chit-chatting with the scrubbed in person. You got to speak up and you can't be nervous. What we need to do is try to ventilate them with pure oxygen. The fastest way to get the gas anesthetic out of their system is to turn off your vaporizer. What I do is I then hit the flush valve. Remember, I said there's only a few times you use the flush valve. Testing your machine in the morning, filling up the bag to recover the patient, or doing CPR. So right now, if you hit the flush valve, you're going to dilute out the anesthetic in the system. Okay, so that's going to be the fastest way, is to hit that flush and flush out that anesthetic. And then what I'm going to do is I'm going to bag the patient, try to warm them. Now, whether you're going to reverse them, if you're just concerned that they're a little deep, you may not reverse them. But if we're concerned that they're excessively deep, we'll probably give antecedent if they had dexdomitor. Okay, you guys are not using pure agonists in surgery. You're using butorphanol and buprenorphine. Both of those are not fully reversible. So and like I said, most of the time we don't have to reverse a dog with butorphanol because it's an agonist antagonist. So most of the time you're going to just reverse the dexdomitor, and then the thing is, hopefully your veterinarian is available for you guys. Dr. Paul and Dr. Ritz are there, and Mrs. McClure. You guys can all watch and make sure that the anesthetic is, like I said, turned off or discontinued. Now, if they're pale, now this is what's interesting is, were they pale when they came in? So if they're pale when they came in, then we have to determine, are they anemic? Did they lose blood? Do they just have really crappy blood pressure? Or were they normal before surgery and now during anesthesia they're pale? So there is the pre-existing, like you already knew about this, or are they losing a lot of blood in the surgery? It's your job to pay attention to anesthesia. You shouldn't be watching the surgery, but I'm always kind of peeking over and kind of looking at, if they're in the abdomen, do I see a lot of blood? Do I see a lot of bloody sponges? And I've had surgeons very focused, and literally they, I kind of have to go, hey, you got to talk to me. So sometimes they get tunnel vision. Did you give an agent that causes vasodilation or vasoconstriction? Hopefully you guys in radiology know the drug I'm talking about that makes them look pale. Does anybody want to stab on the chat if you're actually still here? And hopefully people are still here and listening to me. Awesome. I love you guys. Thank you. Dextometor. So, and you guys hopefully have been seeing it during radiology. These guys are going to look very pale on that drug. So am I as concerned during surgery if I gave dextometor? Probably not. But if you didn't use Dex, I may be concerned. And of course, when they get cold or they're painful, sometimes they will become pale. So you have to be cautious about that. What you can do is make sure they're not too deep, and then check their other vitals. Do they have a good heart rate and a blood pressure? If you have pale dog and they have a crappy heart rate and a crappy blood pressure, I'm more concerned than a dog that's pale with a good heart rate and a good blood pressure, if that makes sense. Remember, I said to you guys a long time ago, you can never look at one value and just judge a patient based on that value. Okay. So, and also I would let my doctor know, say, hey, FYI, this patient's pale, did not get dextometor, blood pressure doesn't look great, I'm concerned about heart rate, and kind of connected to color sometimes is capillary refill time, which is anything over 2 seconds. So again, now, usually what happens if they have a really crappy blood pressure, the blood cannot get from the heart to the rest of the body, or it's compromised. So did they have it before induction? Did they come in with a crappy CRT? If they did not, then what I might be is like they're too deep, they have low blood pressure, or they've lost blood. And those are all situations where you need to talk to the doctor, okay? So, palpate a pulse, feel for the femoral pulse. Remember, and the other thing is when you guys are in surgery, if you can't reach the back leg because the surgery and they're draped, when you open their mouth, you can feel on the bottom of their tongue, because they'll be in BD, there is a lingual artery, and you can put your finger on it and feel for a pulse. So if you can't, like I said, I've bumped surgeons out of the way and said, I got to feel a femoral pulse, and I can reach my hand under the drape, not the surgical field, but I can reach up and feel a femoral pulse. And then do they have do they have tachycardia? Do they have, and sometimes at the end of shock, they get bradycardia. Early shock is more tachycardia. But they might, if it's low blood pressure, and this is a good slide. Slide 48 is, what do I do, which I've already kind of explained in shock. What do you do for low blood pressure? One of the number one reasons that I battle blood pressure during surgery is your inhalant. Isoflurane and sevoflurane, the biggest side effect is hypotension. Next would be hypoventilation. And by nature, The higher you run them on ISO, the higher the degree of hypotension. So typically, I used to call those drugs dial a blood pressure. I literally could turn my vaporizer till I liked their blood pressure. Now, again, it's not instantaneous. You're not going to like go from 2% to 1.5% and then see your blood pressure, but you, within about a 5-minute period, you can see an improvement just from turning down the anesthetic. I mean, and I'm going to tell you, if you are keeping these patients higher than 2.5%, you're going to have blood pressure issues. The criticalist I worked for, wonderful doctor, super smart. When we were in surgery with him, he goes, I don't want my patients higher than 2.5%. He goes, if you keep having to turn them up, you tell me, and we'll give them morphine or hydro or butorphanol, whatever analgesic, we would give them more during surgery. Because he's like, there's no reason to be higher than 2.5%. But a lot of clinics will just turn the vaporizer and just forget about it. But I'm telling you, ideally I like my patients around 1.5. 1 would be really low on ISO. You might run it, but 1.5, maybe 2 is a good place to live. Again, once you get to 2.25, 2.5%, you're going to see more of the side effects. So try not to also use vasodilation drugs. So propofol causes vasodilation, but it usually goes away in the first 5 to 10 minutes after you give it. Acepromazine causes a lot of vasodilation after you give it. Those are probably the 2 main drugs. So like if I have a patient with pre-existing hypotension, I might really use low propofol. I usually try to stay away from acepromazine or use very, very low acepromazine. If turning them down does not work, then give them a fluid bolus, usually 10 to 20 mils per kg per hour, but the doctor will usually, I'll say, what fluid bolus do you want me to give? Like how much? Because your patients will be on a surgical fluid rate, which I believe is like 5 mils per pound or 10 mils per kg. But you can see this is double that. So sometimes they'll just have me double the fluids. But again, if you have a little patient, neonate or pediatric patient, little kitten, if you have a heart disease patient, you don't want to bolus fluids in heart disease. So there's certain cases where I don't bolus fluids, but for your everyday patient, sometimes just a little boost of fluids will do the trick. If fluids by themselves don't work, you can add a colloid like vet starch. And then there are drugs to stabilize blood pressure.
Yeah.
I will write down what I was talking about. Now there is a drug called, I just typed it in the chat screen, there's a drug called dopamine, which is called, it's a positive inotrope. So it is a drug, you give it in a drip and it will increase the tonicity of the vessel, which makes it tighter, which will hopefully increase blood pressure. So that might work. You might be able to do that. And keep them warm, but you can't just put a heating pad on them to treat blood pressure. So really turning down your anesthetic, fluids, possibly colloids, and then maybe positive inotropes. Now, dyspnea, difficult breathing, is very rare because your patient should have an endotracheal tube, be on an oxygen tank, getting continuous oxygen flow. But if you see abdominal breathing, cyanotic membranes, then something is happening where they're not getting adequate oxygen. One thing that I don't know if I stressed this in the lecture, but if you've got a little kitten and you've got all these drapes, sometimes I've had surgeons, they put the instruments on top of the patient. Like they take them off the Mayo stand, and while they're using them, they lay them on the patient's chest. I don't like that, first of all, because if the animal breathes, and what if the instrument falls off the table? Then I got to open them a new instrument. But you also have to be careful if there's heavy instruments. The animal has to be able to breathe. And also, I've seen scrubbed in assistants like leaning on the animal's chest during anesthesia. So you want to make sure, as the anesthetist, look at your surgery people. Are they pushing on the chest? Are they laying stuff on the chest? Are they too deep? Or remember, like obese dogs tend to have very shallow respirations because they have a lot of weight on their diaphragm. And are they not breathing adequately enough to take in the oxygen? If you think they're having trouble with cyanosis or oxygenation and you're worried about a machine malfunction, remember, this is a very good tip. I actually got a call from an intern, and I had told her this tip, and she said it actually helped save a patient. That she had a Chihuahua that was having a hard time breathing during the anesthesia, and she kind of started to panic, but she quickly disconnected the patient. And once she disconnected the patient could breathe normally. Well, now it's not an endotracheal tube issue. It's not a patient issue, because the problem resolved when she disconnected the patient. So she switched anesthetic machines and found there was some plug, or the valve wasn't working properly. So all she did was get another machine and hook the patient up to a different machine, and then the patient was fine. But the quickest way to solve that problem, because there's a huge checklist to go through, was disconnect the patient. Does it solve the problem? Now, my patient that had the kinked endotracheal tube, the problem was when I disconnected, the patient still had the problem. Well, then I didn't have to spend 5 minutes troubleshooting the machine. By doing this, I cut my list down to this, if you see what I'm saying. So you have to make sure you have oxygen in the tank, flow meters on, and is everything hooked up? I follow the flow. You have a tank on, you have pressure, you have a flow meter on, your tubes are hooked up properly, your bag is hooked up properly, my bag isn't leaking, my pop-off is open. Follow the flow. Do I have condensation in my endotracheal tube? The other thing is, if I bag my patient ventally or manually, does it improve? Okay. The two parameters I look at when you're monitoring for this is, what is your SpO2, which should always be 95 and higher. I don't care what species, always higher than 95%. And then you look at your CO2. If sometimes these guys that are not breathing well will have a very high CO2, and then maybe it's the soda line. Maybe someone didn't change the soda line. So again, you may have to get another machine or hook up more tubing. I've done that before too. I've changed tubing. I've put new tubing on. You guys are using in surgery, if you remember this from lecture, the rebreathing system that we have at school, it's called a coaxial tubing. It's a tube inside a tube. Instead of having a Y piece that's two pieces that narrow into one, there's a blue tube on the inside of a clear tube. My anesthesia board, I'm on a anesthesia group on Facebook, and someone had posted problems with the CO2 in a patient. And I typed in there, I said, that inner tube can be cracked. So what happens is when the animal exhales, the inner blue tube was cracked. So the patient was inhaling CO2 coming into the crack in the blue tube. So I'm not a huge fan of the coaxial tubes. It's supposed to keep the patient warmer, but it's hard to find holes and cracks and things the way it's designed. And so that's just something to think about. But bag the patient doesn't improve the problem. Also, if you have them excessively deep, you can get cyanosis or low SpO2 if they're not breathing enough. The way you treat all that, turn them down, bag them, or bag them. Now I've given you some parameters. Now, the only thing in dogs is, I always said, does their heart rate drop? 50% of their TPR heart rate is my best guess, because again, below 60, if you have 60 beats a minute in a Great Dane, that's awesome. If it's a Chihuahua, no. So tachycardia is usually higher than 140 or 160. Cats that are above 200 to 220, that's pretty fast. But a lot of times that can come from drugs like ketamine. Can be a pre-existing condition if you have a hyperthyroid cat. Remember I told you hyperthyroid cats often are tachycardic due to high metabolism or high circulating thyroid hormone, makes them edgy. A veterinarian has to decide if you're going to treat it. Now, treating tachycardia, oh, and also this can be from low blood pressure. It's not on this slide, but if the blood pressure is dropping, the heart's natural response to increased blood pressure is to try and pump harder and more often. So sometimes in shock, that's why they're tachycardic. Sometimes it's pain, sometimes it's stress. So if the patient's painful, they might need pain meds. The patient can be light. So you have to say tachycardia doesn't fit into one mold. But again, if my patient is light, the respiration rate is probably higher, blood pressure is probably higher. If my patient is low blood pressure tachycardic, is my respiratory rate dropped? Is my blood pressure reading crappy? Are their eyes centrally rotated? So you have to look at your other values, your other parameters. Now arrhythmias, there's many different types, and they're usually, I didn't go through all, you guys did this in Tech 4, but there's usually tachyarrhythmias and bradyarrhythmias, like sinus tachycardia is a tachyarrhythmia. Heart block is a bradyarrhythmia. VPCs is typically a bradyarrhythmia, but it can be from poor oxygenation, poor blood pressure, acid-base disorders. It can be from myocardial damage. Well, what damages the heart muscle? If they get hit by a car, if they have cardiomyopathy. So are hit by cars and patients with either hypertrophic or dilated cardiomyopathy, they have some degree of myocardial damage, and I worry about arrhythmias. You'd have to do an ECG, and whether you're going to treat them, I mean, arrhythmias have very different treatments depending on the arrhythmia. So you would need to, if I see any arrhythmia, I always tell my doctor and say, do you want me to treat? What are we going to do for it? Tachypnea, which is, remember, tachypnea versus hyperventilation. Tachypnea is fast and shallow. Hyperventilation is fast and deep. So tachypnea can be seen in obese, and it can also be seen if they're too deep. They get these short little shallow breaths. So check your temperature, but again, if they're tachypnic because they're deep, you're not going to turn them up. If they're tachypnic because they're painful and they have a high blood pressure and they're tachycardic, then you're probably going to turn up the patient. So you got to get to the reason behind the tachypnea, and it will vary. The other thing, again, if it's surgical stimulation, so these slides 54 and 55 are really good, then you might want to give them some more pain meds. If they're obese and they're breathing shallow, you just need to breathe for them. That's what you'll need to do. Ventilate for more of them. Now, bradycardia, again, less than 6 to 70 in a dog, it really depends on the dog. Again, if I have a big German Shepherd, a big Rottweiler, a big Mastiff, those heart rates don't bother me at all. But again, if I'm a Chihuahua, a Pomeranian, a Poodle, those would make me extremely nervous. If it drops below 50% of their presenting heart rate, you may need to treat. Now, did it come from drugs, which we all know by now which drug causes bradycardia, which is typically dextometor. Did it come from vagal stimulation? If you had a really hard time intubating and it was traumatic, you could have stimulated the vagal nerve. Did it come from that? It can be from they're just too deep. Like if you don't turn them down and they just keep going down, 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 down. This is the key here. May not require treatment. It really depends. If you have that gradual dropping heart rate and then it levels, I don't treat it. If it's dropping slowly, 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 turn them down maybe, and it'll come back up. If it's vagal and it drops like that, if you're watching me, you see me dropping off a cliff, then you got to treat it with atropine. The criticalist, he always wanted to know the blood pressure because the heart's job is to maintain perfusion and blood pressure. If an animal, like I said, a Great Dane has a low heart rate so that their heart can pump efficiently to the whole, it's a big body. When a Great Dane's heart beats way too fast, they don't get blood out to the body because the heart cannot fill. That's why their heart rate is slower. So, but again, if it drops too rapidly, atropine or glycopyrrolate, atropine is more like immediate for emergencies. Glycopyrrolate's a little more preventative for bradycardia. And then you can try to reverse them, or again, if you bag with 100% oxygen, if you turn off your vaporizer and just use your flush valve and keep filling your bag with 100% oxygen, you're going to wake your patient up and hopefully come out of the bradycardia. Now, that should be ECG on this slide. Again, VPCs, dropped beats, tachycardia, arrhythmogenic drugs, which means drugs that cause arrhythmias. Alpha-2s like dexmedetomidine can cause arrhythmias. Sometimes ketamine can cause arrhythmias. If it's from a drug, it might go away. If sometimes you might just have to give some oxygen and it goes away. I never treat an arrhythmia without talking to my doctor. I have given dogs atropine under pre-approved, like my doctor says, if the heart rate drops, I want you to do this. And when it does, I do it. But treating arrhythmias is a whole different ballgame. So I would always talk to my doctor, try and print a strip so you can look at the arrhythmia, but you're going to have a constant ECG. The other thing is some arrhythmias come from poor oxygenation. So if you have an animal that's having a hard time breathing, if they have low oxygen levels, then sometimes I try to ventilate. Some VPCs come from hypoxia. And by ventilating the patient more often, the VPCs go away. And I never even had to give a drug. I just needed to get the patient in a better oxygenation status. Okay? So there are drugs. Atropine is not an anti-arrhythmic drug. Well, I guess it does treat heart block. But atropine or lidocaine can be given. And again, lidocaine without epinephrine. Now, most of the time in your crash boxes, the lidocaine in there should be without epi. Remember, though, I talked in local blocks, you can buy lidocaine with epinephrine added, but you would not use that for an emergency. Okay? So can you treat any problems? Now, two things that I've talked about, well, I've talked about apnea. And apnea is a temporary cessation of breathing. So like when I give propofol, a lot of times they stop breathing for maybe 2, 3, 4, 5 minutes. It usually starts to come back. And in that meantime, I bag the patient, I tube them, I have control over the situation. Okay, so I know if you're using propofol, you have to understand what the drug does. That is a normal effect of propofol. Does it happen to every patient? No. But the higher the dose and the faster you give it, the more likely you are to cause a brief apnea. Now, it can happen a lot after IV induction. It can sometimes happen, sometimes when they're in the chamber, they hold their breath. Now, their breath holding, they're usually not apneic. They're just being stubborn. So when you get them out, now, this is a very important on slide 59, this second to last sentence. Patient may not require treatment. If the heart is good, the pulse is strong, the mucous membranes are good and the saturation is 50 and the CO2 is 40. For example, when my patient is given propofol and they are apneic, most of the time all their other vitals are normal. Good blood pressure, good CRT, good SpO2. Even though they're not breathing, it's not affecting any of their other vitals. I don't treat that. I ventilate my patient till their own ventilation comes back. Again, within 2-5 minutes, they should start breathing on their own. Now, if your CO2 is in the 55, 60 range, you probably need to ventilate more often. So what is the difference between apnea and respiratory arrest? Respiratory arrest is what's going to happen if we don't treat, well, if the apnea doesn't go away. And it means when prolonged apnea comes after an overdose. But what happens is, what are our warning signs? Is, well, either they were apneic and they've never started again, or their respiratory rate was going from 12 breaths a minute to 8 breaths a minute to 6 breaths a minute to 4 breaths a minute. That's a ding, 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 ding. My respiratory rate's falling. Do something. So you need to look at their other vitals. And then what you're going to do is you're going to try to get any drugs off the patient. Look at their mucous membrane color. You got to tell the doctor, put in a tube if you don't have a tube in, but most of the time, since I'm talking about general anesthesia, I'm going to assume you have a tube in. Make sure your respiratory rate is good. Turn off your vaporizer and double check your flow and start breathing for your patient. Now, if it's truly respiratory arrest, you're probably going to start reversing drugs, maybe going to stop the procedure. There are definitely cases where we've had anesthetic problems on induction and we woke the patient up and didn't do the surgery because something happened significant enough at the beginning of the procedure. Okay. Now, this is where I'm stopping for this test because what I'll do is we'll start tomorrow with cardiac arrest. And I'm also going to give a handout that talks about the general flow of your duty as an anesthetist because that's kind of what we're going to cover coming up. Now, something to be aware of, and I will send an email to explain this in detail, is remember next week is week 8. The final will be on Monday. And then Tuesday, Wednesday, Thursday groups, I'm going to have you in the building probably from 1 to 2:30. I mean, we could be there only an hour. It could be 1 to 2:30. So it's kind of in the middle of when we would meet online. And what we're going to do on that Monday or that Tuesday, Wednesday, Thursday is go through a machine. I'm going to set it up like there's a patient on it so you can bag. We'll look at an ECG. And then I have an anesthesia checklist of all of your duties. So that will be coming up. One thing to talk about, and let me see. Oops. Whoa. Okay, I thought I lost my chat screen. I'm trying to end with everything. I put your exotics test in. I talked about expectations with the question, making sure you're reading the whole question. Don't cut yourself off at the end because sometimes the answers aren't complete. I just don't, I'm hoping to impress upon you that you have to do certain things a certain way to be more successful in surgery. So just these last 2 weeks, I really want everybody to try hard and be focused as what, because like I said, in 2 weeks, when you're doing it live for the first time, I will tell you guys, next term, I am completely online. I am not in the building because I have had students ask, it's the day before surgery, can I go through a machine with them? Um, Arrangements could be made where I could meet a group of people in the building and potentially go over some stuff with people. I'm willing to do that. I just want people to realize I'm not going to be there in September, October in person in the building. But if you needed to go over a machine with me, it could be arranged. I could set up a Zoom at night to talk about cases. I'm willing to do that. And let me say, I know people are probably, don't drop off just yet. I do take to heart um, my reviews, and I have to apologize. The way this class was set up this term, I struggled with the format and getting the videos. It took a little more, and the Tuesday ones didn't, affected the Tuesday group. I tried to extend, the deadlines, but I've tried to post the video reviews to YouTube and send it out. So, I've learned a lot of, nobody ever wants to be the guinea pig class, but, you guys were in a class format that I've never done before. And I've definitely learned some lessons, so some feedback that I got on my review, I do take that to heart and want to make some changes. I know we're almost done, and then you're not going to have me anymore ever again, but I do take that to heart. The only thing I don't apologize for, and I tend to get this sometimes on reviews, is telling stories. And hopefully, I used to have teachers that told me stuff, and little tidbits of little stories would sometimes stay with me, and I would remember things when I was in rotation or out in practice. So I do think, okay, sorry, you have to go. I know. I continue to tell stories, so hopefully you learn something, not trying to waste time. It hopefully, it gives people, learning anesthesia is through experience, and learning anesthesia is example. So anesthesia is a lot of case-based learning or examples. So that's the only place I've been coming from, is to try and give you guys some of my real world experience. So that will never change for me. Not everybody is going to like how someone teaches something, and that's okay. I'm not everybody's cup of tea. But I apologize for the format. I apologize if Tuesday stuff, didn't delay. Hopefully compensating, giving a couple days for the test helped. But anyway, test will be live here in 10 minutes. If you already attempted it, it was resent to you, so you'll have to restart your test. Hopefully that doesn't mess up your test. If you have an issue, text me. I will be in training at 4 o'clock for our new grading system. So if I don't answer right away, it may be that I'm live with a person. Okay, you guys have a good day. And actually, I got it. Does anyone have any questions? Okay, you guys all have a good day, and let me know if there's any issues. Okay, well, I'm going to end this so I can get it converted. All right, bye.